Welcome everyone to this first all-team brief about the Cancer Hospital. Firstly, for those of you that don't know me, I'd just like to introduce myself. My name is Sarah Jeffries, and the reason I'm here today is that I'm the Clinical Director for Cancer here at CUH. Just a couple of things to reassure you. For those of your colleagues who haven't been able to join today, we are recording the session, so that link will be uploaded. And we will try to answer any questions that you may have, but if you could kindly pop them in the chat, we'll try and get to them at the end of the meeting. So, why have we asked you to join us today? We know that staff involvement is absolutely crucial in planning this design and delivery of what we're planning to be a world-class cancer hospital. So the all-staff briefings will be a regular feature. We're planning to have them every quarter of the year. And what we're hoping to do is to get regular sort of feedback from you, and many of you will be asked to join us in groups so that we can take into account your thoughts and ideas as we plan ahead with this amazing opportunity as a project. So today what we're going to do is we're going to go for a sort of, I'm just going to give you a bit of background. We're then going to have an overall briefing of the project, which will look at where we are, what needs to be done, and most crucially bringing in the elements of research that are going to be integral to this hospital planning. So I thought to set the scene, particularly today, it's very poignant today, isn't it? It's 12 months that we've been affected by COVID, and many of you will have been already on some of the reflections that have been offered up by CUH this morning. So personally, while thinking about bringing the sort of starter to this project for you, I'm very aware that a talk I would have given on the 23rd of March last year would have been very different to the talk that I would give today about how we might plan our cancer hospital. And what I'd like to do is to share with you three sort of examples of what we've learned in the last year that I will think will make the way that we work in this new hospital be able to be sort of world class. So the first thing I'm going to ask you to do about, you'll come here because you've heard the word cancer hospital and you'll be thinking buildings. So I want you to free your mind about bricks, mortar and space, because the most important bit about the cancer hospital is you and the patients and how we design the infrastructure of the building to work with us. And we've had a little taster of that last summer. So some of you will have been involved when we had to very rapidly take our haematology and oncology service to the Nuffield Hospital. We had to do it very quickly, and we learnt very easily that a well-designed modern build was a very good environment. It was loved by patients and by staff. It reduced our infection rates, and it created a very sort of safe, world-class really treatment environment for patients. But we also learned that communication was absolutely key. We had to do things very quickly, which will be different in planning for a cancer hospital. And we needed to not only think about medical staff and patients, we needed to think right through from receptionists to EPIC programmers. And we really missed being on a separate site, some of our crucial services in that very short interval. So we missed our palliative care teams, we missed our bereavement office, we missed our specialist nurses. So we need to look at things that we've achieved, which gave us a fantastic care of our patients in those 5 months that we relocated, and use those learning lessons for when we move to our new site on the campus as a cancer hospital. When we also think about infrastructure, our whole working lives have changed. All of you, we've all done things completely differently. So we've managed a mass scale move to delivering consultations by telephone and by video consultation. We've taught patients to give their own medicines at home to reduce hospital visits, and we've optimised our ambulatory care both on site and also out in the locality. And many of you will know that the diagnostic hubs, and particularly blood taking off site, has revolutionised things, particularly for patients. So the way we need to think about our new cancer hospital is going to be a central hub that some patients may never actually visit physically, but the cancer hospital will be providing their virtual but world-class cancer care. And then finally, in terms of the thing that we're here for, is that most research we think about in the clinical arena is within clinical trials. And what we've learned in the last year is is that we can now access patients remotely for clinical trials, and we can obtain consent remotely. And this has massively improved equity of access for patients, and it's something we need to build on to consider. We've also seen within our own hospital and nationally the huge effect that the COVID research studies have had, and we need to learn from those. And all of these things, bringing them together, we'll be aiming for a trial for every patient who either physically or virtually attends the Cambridge Cancer Research Hospital. So really those are my reflections of some of the positives that have come out of what has been without doubt a very difficult year. And what I'd like to do now is hand over to Hugo, who will tell you a bit more about where we are with the planning and how things will move forward. Thank you, Hugo.
Thanks, Sarah. So I've probably disappeared from all your screens, but for those of you who don't know me, I'm Hugo Ford. I'm an oncologist. I'm the Divisional Director for Division B, and I'm also the Trust Lead Cancer Clinician. So what I'm going to do is just very briefly go through a little bit about how we got to where we are, what the proposal is, and then perhaps Richard can talk about some of the research aspects when we get to it. But just a little bit of background for those of you who haven't really been involved. The oncology and haematology clinical services we have are really quite widely spread around the site. And the Oncology Centre in particular is in one of the oldest bits of Addenbrooke's, built in the 60s. We have a lot of problems with infection control and with privacy and dignity. We have a significant shortage of side rooms. And our inpatient infrastructure, particularly the transplant ward, is really not fit for delivering modern transplant cellular therapies. For outpatients, we simply don't have the capacity to cope with the number of treatments that we're currently giving, let alone being expected to give over coming years. So it's been clear for some time that there needs to be some significant investment in just the clinical infrastructure to get us into the next century, as it were. At the same time, we've got some significant national challenges with cancer treatment. We know that although they're improving, our outcomes as a country are significantly worse than most other developed countries. And there are a lot of reasons for that, but nevertheless, it's a constant theme that we really need to address. We've also got more cancer. We've currently got about 2.5 million people living with cancer in this country, and in the next 10 years, that's expected to almost double to 4 million. And along with that comes the rising cost of cancer care. And we estimate that cancer care in the UK costs £7.5 billion, and that's increasing roughly 10% a year, which we'll all be aware is very significantly more than the rise in health budgets. Locally, we've got a lot of pressure on inpatient capacity, partly because of the numbers of patients that we see, but also partly because of the rest of the hospital being incredibly busy. And we've seen that obviously through COVID, but even before then, the constant pressure, particularly in the winter, from the frail elderly and general admissions, which does restrict the availability of inpatient beds for specialist services such as cancer. And I've already talked about the clinical environment, which is really pretty terrible for breaking bad news, or for looking after unwell people with privacy. We've got some very exciting opportunities though. We've got a very strong research community, and Richard will talk about that in a minute. But strengths across a number of sciences, including non-biological sciences, physical sciences and STEM subjects. We've got a very strong clinical community, and in fact our outcomes are very good compared with national standards and compare very well with international standards. So we've got a fantastic community of clinicians, nurses, support staff, AHPs, who really do deliver good outcomes for our patients. And we do recruit already a high proportion of our patients to clinical studies and clinical trials. And we believe that's one of the ways to actually ensure that people are getting cutting edge care and are getting the best care. And also around Cambridge, we've got this amazing local economy with lots of pharma and biotech, innovative new companies, which gives us the opportunity to really think about what are our local chances for tackling this big clinical problem of cancer. So what we've proposed and had been in the pipeline for some time is a new cancer hospital on the campus. And it's not just, I hope, tried to say that we really want it to be co-produced with patients as much as possible, particularly with regards to the clinical pathways involved. And what I mean by digitally enabled is the data generated not just in the hospital, but from the patients coming through pathways across the region. We will be able to use that both to communicate better with patients, to get better information about patients, but critically as a substrate for new technologies like artificial intelligence to really work on how we improve those pathways for patients not just in Cambridge but across the whole region. So what we want to do is to revolutionise our staff experience, our patient experience, and really at the same time be making a major contribution to improving outcomes, particularly through early detection and better treatment of cancer. So where will this be? What you can see on the easily identifiable here is the AstraZeneca, new AstraZeneca headquarters. This is the proposed location of the cancer hospital, directly opposite the ATC. This is the Frankley and the Hexagon, and up here is the Geoffrey Cheer building and the CUH Cancer building, Cancer Institute, and here the LMB. So it's right in the centre really of all the laboratory research that's going on into cancer on the campus, but also critically adjacent to where a lot of the major surgery happens, and within good close distance to other important facilities like intensive care. What's proposed to be in it? 79 inpatient beds, all single rooms, an outpatient centre, an emergency centre, the cancer assessment unit, a wellness centre which hopefully will include psychological support, rehab, patient information, an imaging centre with PET, CT, MRI and ultrasound, and then 3 university institutes for early detection of cancer, integrated cancer medicine and breast cancer. We've had to make some decisions about what doesn't go in, and that's always challenging. Radiotherapy, the radiotherapy facilities that we have are currently are in pretty good order. It would be very expensive to relocate, and we've taken a view that at the moment we're not going to move radiotherapy into the new cancer hospital as part of this first phase. I think as the radiotherapy site nears the end of its life and will need to be redeveloped in the future, then we will look to redevelop it adjacent to or as part of the cancer hospital complex. We've had again discussions about surgery, and the general feeling is that again the advantage of bringing surgery into the cancer hospital is probably not outweighed by the very significant expense and increase in scale that would cause. We have fantastic outcomes from the surgery that we have in the location and by the teams that's being carried on. Intensive care, similarly, intensive care has a very good model with remote monitoring and so on. And after conversations with the intensive care team, rather than have a dedicated unit in the cancer hospital, we'll be working very closely with them to deliver the necessary support to our patients. Paediatric oncology will be in the cancer hospital, although there will be a teenage and young adult unit in the CCRH. An aseptic pharmacy, because the plan there is to develop a large aseptic pharmacy which will cover all the Cambridge hospitals for parenteral nutrition as well as cytotoxic chemotherapy. So where have we got to? So after some pretty intensive work, background work and lobbying, the Prime Minister announced the CCRH funding from the government in October 2020, which is really the trigger for a lot of positive action. So we've just submitted the strategic outline case, and we're sort of going around the houses again a little bit because a lot of this work had been done before, but we've had to update it partly in the light of the COVID epidemic and partly just to comply with the Treasury regulations. We're working with the Department of Health and Treasury in wanting to be included in the first round of the National Hospital Improvement Programme, and we're hoping on getting £150 million of government funding for the cancer hospital. The university elements will cost about £50 million, and that's planned to be raised through philanthropy. And then we're engaging with a number of other partners, including Cancer Research UK, Macmillan, that should say the TCT, not the TYA, that's the Teenage Cancer Trust, AstraZeneca and others. Some of whom may contribute through fundraising, others will contribute in other ways, but all of whom are very happy and positive about their involvement. A rough timeline, and this is only very rough, but I think if we look at the bottom right-hand corner, if everything goes well, we're aiming to be constructing this hospital through 2023, 2024, and opening either towards the end of 25 or early 26. So quite a tight time frame for delivery. And our next steps are going to be further engagement with patients and staff over the design and critically over the patient pathways. And we're encouraging people to think about, if I was a patient, and indeed we're asking our patients who are patients, how would we want care to look? And then we've got to work on what we need to do to get there. Part of that is going to be designing the hospital and so on. And part of it, as Sarah said, is going to be how we design the out-of-hospital pathways as well. We've got to do, the nuts and bolts, the financial and activity modelling and all that. And we're aiming to submit the draft outline business case to NHS England in June, probably with a final version going through in October 21. So that's sort of where we are at the moment in terms of our planning. I think that's all I had. So if I perhaps hand over to Richard now, Richard, who's the Chair of Oncology at the University of Cambridge, who can talk to us about some of the research side.
Great, thank you, Hugo, and thank you, Sarah, for such a good intro. For those of you who have not met, my name's Richard, Chair of the Department of Oncology, but I direct the CUH's Major Cancer Centre here. So why do we bother to have research in the cancer hospital? That's not a bad question, actually. So if we think about what this country, and in fact the world, wants to achieve in terms of cancer in the next 20 to 30 years, the major ambition is two things. The first of those is early cancer detection. So we know that if we diagnose most patients with cancer just as it's beginning, or even better, before it starts, and therefore we can intervene before patients even know they have cancer, we have the maximum opportunity of curing them. So the NHS long-term plan that we're working to at the moment has the ambition of actually increasing the numbers of lives saved, but within 5 years by 55,000. That means increasing the numbers of patients diagnosed early to 75%. That's a huge ask. How are we going to do that? That's a good question, and that's what this hospital is about. The other aspect is, how do we treat patients more precisely? So rather than walking in the door and saying to a patient, you've got this kind of breast cancer, or you've got this kind of colorectal cancer, or you've got this kind of lung cancer, therefore we look up in a book and you have these treatments. What about your Mrs. X, you're 45, your tumor looks like this. This is what your genetics say, and so this is the kind of treatment we're going to get you. That's the sort of intervention that we want. So actually the way we'll do that is partnering with all the fantastic people on this call, the healthcare providers, physicians, scientists, surgeons, and also, of course, allied healthcare professionals who work with them, but also people who don't usually work on cancer, physicists, engineers, chemists, mathematicians. And they're the people who we're building this building for as well. So in early cancer detection, we've made great strides in that by using the engineering, the physics, the mathematics know-how of Cambridge to bring that to patients. And Sarah made a really good point at the beginning. This is actually not just about bricks and mortar, because of course, if we're going to diagnose cancer early, it's not going to be in Addenbrooke's, it's going to be in Boots, your corner shop, or even in your front room at home. That's where it has to happen. We have to make cheap and simple to use devices available to people so they can start testing themselves as soon as possible. One example you may have heard of is the cytosponge that Rebecca Fitzgerald invented here. That's a way of detecting Barrett's esophagus. That's the first form of esophageal cancer that we know of. About 9,000 patients get esophageal cancer. It's on the increase. Almost all of them die. But we could prevent half of those cases using a simple test like cytosponge. GPs can use it. And in fact, Scotland's so impressed with it that their 10 mainland health boards have introduced it. So they do about 65,000 endoscopies a year, and they reckon about 40% of those could actually be replaced or significantly reduced with cytosponge. That saves millions of pounds to the health service, and it saves millions of patients from the trauma of going through to an endoscopy and simply having something in their front room or in their GP surgery. That's fantastic. So what's integrated cancer medicine? That's a sort of posh term that we use to basically take all of the information we know about patients and giving one result. So what I mean by that is, you'll know that we do sort of expensive sequencing, really high-end imaging. We do pathology at a digital level where we turn the image down a microscope into pixels. This is all masses of data in a cloud. And what we're doing is using the latest AI and machine learning approaches, or advanced computation, to turn all of those numbers into single results of patients that follow that patient as they go through their disease course. So we can understand not just what that patient needs today, but what will that patient's disease be doing in 6 months' time, in 10 months' time, in 12 months' time, so we can truly personalize their care. So the two institutes in the hospital will be an Institute for Early Cancer Detection, which I talked about, and that Institute for Integrated Cancer Medicine. One of the oldest and most successful programs in the cancer hospital is in breast cancer, and that's where we have a huge amount of biological know-how, but also clinical experience. And by having that third institute in there, we'll be able to really bring into the hospital the kinds of people who can work alongside you and really start to accelerate our progress of patients with cancer. But the cancer hospital, last thing I want to say is that it won't just belong to Cambridge, won't just belong to people working in Addenbrooke's. So the Early Detection Centre will have space in it for GPs, for nurses, so they can come in from the community and start to help us understand about early detection devices. There's no point in developing a fantastic early detection test if a GP's turn around and say, nobody's ever going to use that. And in fact, what Rebecca tells us from her economic modelling is, if we co-locate these people in one place, you can save somewhere between 3 to 5 years in the development pipeline for just one device. That's massive in terms of the cost savings, but also the potential life savings for patients. It's the same with integrated cancer medicine. If you can bring individuals into there from chemistry, from physics, from engineering across Cambridge, and they can actually get to know what actually happens to patients, that's massively saving. And then also, we want to bring all the bright people from around the world. So we're going to have space in that building where, if you're working in Hong Kong, or you're working in San Francisco, you're working in New York, and you've got a brilliant idea, why not come to Cambridge and develop it with us? And that's the other aspect which will be in that building. But that third one is in breast cancer. And I'm going to hand over to Jean Abraham now, who co-directs our breast cancer program in the centre. She's going to tell you a little bit more about one of those exciting programs that's particularly affecting women and men who have breast cancer. So over to you, Jean.
Thanks very much. I'm going to share screen just so that you don't have to look at my face for all of the time. Sorry, it's okay, maybe I'm not going to share screen. Hang on 1 second. Okay. Right, finally. Can you see that? Yeah, perfect. Okay, so as Richard said, I think one of the key things here is really to understand the impact that it has on our patients and on our staff as well. And as the title of the hospital says, it's Cambridge Cancer Research. And I guess I want to really try and convey to you what impact that has on you and on your patients. So often we think about the patient's questions, and what we see are key questions like, can my cancer be cured? How will I be treated? Will I know if my treatment's working? Are my family at risk? Will my treatment make me ill? Do I need more treatment? And all of those questions that the patient has is often reflected in the same types of questions that the doctors, nurses, and allied healthcare teams have. And Richard mentioned integrated cancer medicine, and one of the component parts of that is the personalised breast cancer programme. And the picture here really tells you about the schema, but to make it simple, this is a programme for breast cancer patients of any stage of cancer who want to come in and consent to have a blood sample and a tumour sample taken. The blood sample will tell us what they came into the world with in terms of their genomics, and the tumour sample will tell us what's changed. We then do is we look at those two aspects, and we discuss in our oncogenomics review board what kind of impact or actions we can take based on those results. And in the box down here, you can see a whole load of jargon that essentially says that there are lots and lots of different types of variations that we can look at. And that is summarized into a report that is lay-friendly and patient-friendly, and it is put into EPIC and also given to the patients. And then what we see are the various types of impact that these results can have on the patient's care, and they're quite varied. And you can see here that we might find incidental other cancers. We refer to our colleagues in clinical genetics a great deal, and it has a very large impact on family screening, and about 1/3 of our patients actually have this kind of impact. We've so far had 800 patients recruited to the study, and about 700 patients have been through the oncogenomics review board. I'm going to place this in the setting of the integrated cancer medicine theme, because you can see here, this is where the oncogenomics review board is, and the tumour and the DNA work are really just part of that pathway. And what we hope to do in the Cancer Research Hospital is really, by co-locating, bring all of these different data streams together and feed them into our molecular tumour boards, and then into the traditional molecular tumour boards, multidisciplinary team meetings. And what we can see is that by doing that, and by using AI and predictive algorithms and prognostic algorithms that can be accessed around the region without actually having to come to Cambridge, that we can in fact democratise the care and share our expertise. And what you'll find is that already patients are coming to their GPs and to regional hospitals with genomics testing that they've had done themselves or paid for. So this kind of care is needed now, and really the Cancer Research Hospital will bring it into a formal and well-structured setting where we can deliver this to everybody. I think that's all I need to say.
Jean, thank you. That's fantastic, and a real example of how, you know, we can make the science real and deliver real benefits to patients. I think the next thing we've got is a short video from Raj Jena, who's one of our clinical oncology academic consultants, about the work that he's been doing using artificial intelligence and machine learning to improve the radiotherapy planning process. So hopefully that'll come online imminently.
When I decided to become a doctor, I didn't realise that artificial intelligence would play such a big part in my life. My name is Raj Jena. I look after patients with cancers of the brain and spine. We do this by using precise radiotherapy treatment to kill off the tumours and save lives. Planning radiotherapy treatment takes many hours, carefully marking up scans in order to direct the radiation to the tumour whilst shielding healthy structures around the tumour itself. So my team at Addenbrooke's Hospital and the University of Cambridge have been collaborating with Microsoft Research to train computers to perform this task more quickly. The results are incredibly exciting. The research, known as Project InnerEye, have shown that a computer can perform in just a few minutes what would normally take me several hours to do. This is important because it means we can start a patient on life-saving radiotherapy much more quickly. And we know that the sooner that we can start treatment, the better the chances for the patient. The deep learning software tools from Project INRAI have now been released as open source code. And we look forward to using these tools routinely to speed up the time taken for patients to start radiotherapy treatment here at Abbey. Using AI to help doctors with complex but routine tasks is an absolute game changer. It gives back clinicians the gift of time, and it means that we can focus on the parts that only humans can do, which is actually caring for our patients.
So there you go. He's not actually a Dalek, Raj. He's a real person. He looks a bit like a computer simulation in that. But that's another fantastic example of how the work that's being done now is changing the way we treat patients. Next up, we've got Claire Holmes, who's the operations manager for the Cancer Directorate, and Claire's going to talk to us a little bit about engagement.
Hi everyone, for those that don't know me, my name's Claire Holmes, I'm the Ops Manager for Cancer. It is lovely to see so many familiar faces on the screen, so thank you everyone for joining us. I'm hopeful that Sarah's going to share a screen for me. Lovely. So one thing has already been mentioned so far by Sarah and by Hugo is around how we all need you to help us with the Cancer Hospital. And that's not in 2026 when the doors open and we all move in. That's helping us from now. And that's both in designing what the hospital will look like ultimately. But really the main thing for me is how are we going to work in that hospital and what can we start to do now to change how we work? All of you have probably worked over the last few months with COVID in a very, very different way to how you have done previously. So many of you have worked, shared sort of roles across working from home and working on site. You've probably all based in different areas of the hospital, different teams, and worked in a really flexible way. And I'm hopeful for a lot of you that that has really worked and shown you what is possible and how we can work differently to not only benefit our patients, but also to benefit ourselves and our well-being, which is really important. So what we really want to do is to organise something we're calling a staff reference group. It might be a new term to a lot of you. This is where we really want people from all across our cancer services, from all different types of professions, all grades, anybody who wants to get involved in this, to really work with us to think about how we can work differently. And all those things within your current day-to-day roles that we might not have thought of and how we can really benefit our services for the future. So what we will do is we will be coming out to all of you via email, no doubt, after Easter to ask if you are interested in getting involved. At that point in time, there is no commitment in terms of how much time you can spend and those sort of things. But if you've got any questions, please do come back to us. But we're really interested in, say, making sure that every profession, every type of role is represented. So those of you out there who think that you are just administrators, I will say, or just HCAs, you're the really important people who we would really want to get involved with this. I will be, as a fellow administrator, I will say that this is not just for our doctors to design this building. We all need to be involved, and I really hope that everyone would like to do that. We're hopeful that we will have quarterly meetings, and you can be very much part of this project over the next few years. So I will hand over to Sarah Vincent, I think, now.
Thank you very much, Claire. Hello, I'm Sarah Vincent. I'm from the communications team in CUH, but I also run the communications and engagement work stream for the Cambridge Cancer Research Hospital. And I look forward to working with many of you going forwards and setting up different opportunities for staff to get involved. And we'll be, as Claire said, sending out an invitation to express your interest in joining the staff reference group after Easter. But I just wanted to mention two other things that our work stream has been working on, which may be of interest. First of all, patient engagement. Patient co-development in this project is absolutely critical to its success, and has been going right from the start, right from the initial concept. We are working very closely with the Addenbrooke's CPPG and Lenya Bell and others to co-produce a model of patient engagement for the hospital. And we're setting up bespoke groups for people to join, and patients from across the campus involved in research and beyond. So hopefully you will be aware of that going forward, I'm sure. And then finally, I wanted to share with you some exciting news, I think, about our new website. So let's see if I can move on to the next screen. It did it when I didn't want to move on to the next screen. Oh, there we go. Launched last week, cambridgecancer.org.uk is a website all about the hospital that we want to build. So this will be developing over the next months and years, and we want to add on news stories about the work that you're doing, life stories about our patients and the people who work here. So this is going to grow, this is going to develop, but I wanted to make sure that you all knew that we have this, and feel free to visit it and have a look around. It's not perfect. Do let me know if you spot things that need to change and need to evolve. But yes, do direct people to it and take a look at it. So thank you. That's all from me, and I shall hand back to Sarah, who I think we're going to do some questions if there's any time left to do questions.
So thank you, Sarah and Claire. That was a good overview of how people can become involved. So we've got just a few minutes, although at the moment, the chat box I can see is empty. Maybe that shows that we've all explained things beautifully during this meeting. Here we are, lovely. So one quick, easy question is, which I'm sure I can answer, will the new hospital be using Epic? I'm sure the answer to that is yes. So there's a very detailed and quite thoughtful question about, which I'll ask Hugo to answer, is about the sort of integration of making the hospital designs tend to be a bit cold and rigid, and have we given any thoughts to, for example, how the walls will have some art therapy, etc., some of which we've seen around this campus, which have been very helpful. Do you have any thoughts of that?
Yes, I do. So I mean, I think that's exactly the sort of thing that we'd like to bring in your help and advice on. I would anticipate that that's not something that the government funding will fund, but it's absolutely something that we should be looking to support through other means. Guy's and St Thomas, as you probably know, has a very well-endowed foundation which provides a lot of amazing art throughout particularly on the St Thomas's side. Unfortunately, we're not quite as well endowed as they are, but at the same time, I do agree totally about the importance of a healing environment for patients, and art as being a key part of that. So we will be looking to support that.
So there are two questions that really demonstrate some of the things that we've been discussing. So there's a question which is a really relevant question, is how will we integrate the Children's Hospital with the Cancer Hospital and the TYA services as transition? So that's something that, as I think I alluded to at the beginning, that's a people, patient kind of pathway issue that we really have to think about. And that's part of that wide angle lens about how will these all interplay? Because of course, we have the Children's Hospital coming alongside as well. Someone has raised a question that is which I'll ask Hugo, is will the location be ideal once Addenbrooke's 3 is built? So are we at danger of being in the wrong location if the new hospital is kind of reconfigured or reorientated?
We'll try and avoid that. I mean, I think as regards surgery, no, I think that'll be fine. As regards ITU, I think, a key part of planning Addenbrooke's 3 will be getting the ITU would be, the main part of the ITU is likely to be in the emergency hospital, but that's still up in planning stage. And I think key part of planning that will be to make sure that we, get the right access to everyone. I don't think it would be much further away even than it is from now, but it's certainly something we would need to think about very carefully. And I can just answer the one about plain film X-ray. There will be a capacity for that as well.
Okay, so I think that's answered the questions that appeared in the box, and if there's no, oh no, here we are. So again, so space often is an issue. So there's a question posted here about, will the building have enough waiting room chairs and space? And I think, you know, again, what we're hoping to do is to move away from the Cancer Hospital as being the major sort of visitation hub, but we'll be planning space, but I anticipate we'll be planning less space possibly than you would imagine, in terms of, because we'll be trying to do things virtual, reduce visits as much as possible. But part of the space creation, Hugo, we've been working on, haven't we, for quite a while, and that will continue to do so. I don't know if you've got anything else to add.
Yeah, I think that it's a fair point. So on the one hand, you know, we obviously do not want to have thousands of people sitting waiting for hours in waiting rooms for treatments, and much better to improve the flow and make things more efficient and reduce their, you know, visits to hospital and so on. At the same time, inevitably there will be some people waiting. What we have at the moment in the design is quite a large number of smaller waiting areas, which are a bit more, I hesitate to use the word intimate, but you know, but less like a barn. And then there will be a big area on the ground floor with access to all the patient information and so on. And we'd anticipate something like Patworth or the UCL building in London, where patients don't go up to their waiting area for the clinic until they're shortly before their appointment, and they have other areas to be in the meantime.
Thank you. So we're bang on 1 o'clock. So I suggest that we'll halt there, but we'll be back again in about 3 months' time to give you our next update. So thank you everyone for joining us. It's much appreciated. Thank you.